Assalamualaikum, everyone. Welcome to another session of our webinar. This is, as you know, ongoing our APPNA MERIT effort to educate, particularly our colleagues in Pakistan, who are clinicians who are dealing with COVID-19 patients or who want to learn more about COVID-19. As you know that America is at the forefront. Unfortunately, we have the most cases in the world. We have most death in the world. So obviously, our consultants are more experienced in that way. Unfortunately, but hopefully things will get better, and hopefully Pakistan will not need that kind of extra response. But if it's all about preparedness. We would like our colleagues in Pakistan to be prepared for a time when it can be just blown over. So with that, I will ask the speaker to introduce himself, and then later on we'll introduce our panelist. So go ahead, Fawad, please introduce yourself and topic.
Thank you, Shahid bhai. Fawad Chaudry. I am interventional pulmonologist and intensivist in sleep at University of Oklahoma, currently serving as assistant professor there. We have had some decent cases of COVID, so I thought I'll share the experience. Also, I've been in some of these, many of these discussions. Along the way, while I was preparing it, I've tried to answer a lot of questions that I felt had been asked in the last few days and had been answered. But there have been different background of people or physicians that are joining us in general. So it will be probably 25-minute talk or a little less than that, but hopefully it will have a lot of answers that many have been asking. So I should start now, right, Shahid?
Yeah, sure.
All right, so let's see why my presentation is not moving forward. That's interesting. Okay, so all right, so as I said, I'm going to go a bit quick. Objective-wise, I have the literature review of these rapidly changing guidelines. I want to answer some of the commonly asked questions. I'm going to discuss the guidelines, treatment guidelines in the US, and the protocols which are institution specific. And then how we can apply those protocols in Pakistan as well. So with that, I'm gonna jump on. I'm having some difficulty. Okay. Basically, what are the biological characteristics? I'm gonna quickly go over SARS-CoV-2, single-stranded RNA, spread from humans to basically spread to humans from zoonotic, likely bats. There is a reference to the paper. In all my slides, what I'm talking about, there are references. So I think we can later on put these slides for for the people who like to kind of take a look at it later on. Routes of infection, other than of course person-to-person respiratory droplet, there is contact and enteric route has been described, and the virus can get shed in feces for up to like 21 to 28 days with some reports. Incubation period is 3 to 12 days. With a median duration of viral shedding of about 20 days. And there has been reports, the initial reports of virus binding to ACE2 receptors on type 2 pneumocytes. But again, we'll talk about the role of ACE inhibitors and ARDS later on. And all these references are very high use studies that I put it down there. Quickly about some epidemiology, attack rate, which is kind of how many at-risk individuals can get exposed by one index case is 30 to 40%. Case fatality, that has been rapidly changing, but this the study from where I got it was about 2 weeks or about 10 days before. So that was about 1.5%, which is slightly higher at this point. And overall 3 to 4%. And we discussed about the incubation that has been previously asked, question 3 to 14 days. And virus shedding that has been previously asked is up to 20, 21 days, and the study references there. Very common, nearly 85% of these patients does have fever, and persistent fevers, up to 10, 12 days of fever is commonly seen. 80% of those patients also have cough. Fatigue is up to 69%. And then about 10%, I think a few days ago, somebody asked about GI symptoms. So again, nausea, vomiting, diarrhea is about 10%. So that is again the reference to the studies there. It would be good to take a look at. But cough, fever, fatigue, these are the main symptoms they're presenting with. Lab abnormalities, all of us know lymphopenia, 80% of the patients do have that. Elevated BUN and creatinine and AST-ALT, especially AST-ALT, very commonly seen. And then if they have high C-reactive protein and ferritin, they do have it, but if it keeps on increasing, that goes with the worsening of the disease. Elevated D-dimers, interleukin-6, and lactate dehydrogenase, LDH. These are all the common lab abnormalities that have been seen repeatedly. And they should be monitored on a daily basis. I have some protocol at the end, which we use at our university, and that I will share with you guys. Imaging findings, I'll go quickly. I think we have discussed previously, they can present without any imaging abnormality. However, so if the index of suspicion is high, please still think about it. When they are getting into the more advanced phase, chest X-ray can show bilateral interstitial edema, CT scan can show VGOs, consolidation, and B lines and pleural thickening with focus or point of care ultrasound. That again is commonly used in many institutions, so they don't have to get to the CT scan. Important to assess the cardiac function, as certain reports and recent papers have suggested 32% involvement of cardiac involvement. So that's also important. These are the go-to investigations, sparing the CT scan that can be done for these patients suspected of COVID. How do we test once you're suspecting? Of course, nasopharyngeal swab for SARS-CoV-2. And then again, remember, co-infection is common. Quite a few times you will find more than 10% of the cases will have a co-infection. So do the PCR20 and Bio5 for influenza and other adenovirus and other viruses as well. And of course, treat accordingly if they're influenza positive as well. Do not order sputum induction and do not do a bronchoscopy unless absolutely indicated. The bronchoscopy indications I'll discuss or intervention indications the next slide according to AABIP. Similarly, do not do PFTs or spirometry, not on these patients. And when the COVID is there, elective PFTs are also not recommended by both ATS and occupational medicine because of the risk of asymptomatic patients shedding the virus. And of course, notify your health department. Okay. And this is the AABIP recommendations for the procedures. So the only procedures we are doing at this point is the emergent ones. And those mostly fall in interventional category, like severe tracheal stenosis or a mass on the trachea that you may have to do a rigid, but we are doing it kind of one a week. That kind of falls on under PEPPER as opposed to N95. Massive hemoptysis, migration of stent. These are some of the emergent indications for bronchoscopy. The more gray area urgent bronchoscopic indications are, for example, BAL requirement in immunosuppressed patients. We are trying to avoid it if they are clinically improving by giving a couple of weeks of antibiotics for 7 days and see how they are doing while in the hospital. Foreign body aspiration, depending on where it is, that can be considered an urgent one. Mediastinal and hilar adenopathy and lung mass is suspicious for cancer. These are kind of rather urgent indications, and we are doing it in a low volume, especially in those patients where it's going to change the management. For example, if the patient, we don't do it, it's going to go from a resectable case to non-resectable case, we will consider it. But certain cases, when you have a suspicion between sarcoidosis and lymphoma and things like that, you can delay it. So these are the only indications I would recommend, emergent and urgent, that you consider at this point in a low volume, and use the air purifying device, which is PEPPER, for these. All right, so going back to the COVID, we kind of discussed clinical lab and chest X-ray quickly, and the imaging quickly. And then we decided how we're going to get specimen. We do not need induction. We do not need bronchoscopy in general. Infection control wise, once you have a suspected person, use the droplet precautions. If you have limited space, especially some of the places in Pakistan where space is limited, you can consider, if you have to cohort, separate the patients 2 meters. Of course, restrict visitors, that we are doing it for every patient and every kind of surgery and every illness. Avoid room entry unless essential. Even nurses, they can have extension to the IV pump, so they don't have to go back and forth in the patient room. Hand hygiene, we all know 20 seconds of hand washing, and if you are using the alcohol containing gels, it should contain 60 to 90% alcohol. Again, I think that question was asked sometime in the last few days. Okay, so what is the appropriate PPE? That has been very commonly asked question. So standard precautions, contact precautions, droplet precautions with eye protection for all the cases PUI as well as positive, plus airborne precautions. And airborne precautions are by N95 or pepper. Now, the current recommendations for airborne precautions are for aerosolizing procedures such as intubation, NIPTV, open circuit suctioning, bronchoscopy, and other aerosol treatments. But we don't recommend open circuit suctioning, and we're kind of trying to avoid NIV anyways. So basically, intubation, extubation, bronchoscopy, and some of these procedures, they're recommending to use airborne precautions. If you have it available, then I think it's reasonable to use it, just going in and out, and for the rest of the patient care as well. But if you don't, at least in those procedures, N95 is needed. And all healthcare professionals should be trained in how to properly don and doff, especially while taking off the PPE. The contamination risk is higher. Multiple studies have shown that. So, so that's important. And also, of course, some fit test is important. For people with beard like myself, when I'm taking care of ICU patients, last week I didn't. So I had it all shaved and with a little specific recommendations, but still I was using pepper if you have any facial hair. Okay, because N95 will not fit. Now I'm going to go over the treatment recommendations and some of the recent studies. And again, I wanted to give you some bullet points of what we need to do. If you have somebody and somebody in the fellows and new trainees, they want to see how we are doing it. So they have the bullet point presentation, what we need to do. Do the good ARDS management, fluid sparing technique, keep them dry, avoid nebulizations, as I mentioned, risk of aerosolization, empirical antibiotics, just like in another ARDS, if secondary infection is suspected. Non-steroidals, WHO mentioned no need to discontinue. However, most expert panelists do believe that we should avoid it if possible, use Tylenol. I talked about the ACE inhibitor or ACE receptors and virus affinity. Again, for American College of Cardiology and American Heart Association, there is no recommendation to discontinue. If they are on ACE or ARB, continue until anything else comes up at this point. What about the cardiomyopathy? Again, this is a recent paper published in JAMA that showed up to 30 to 33% of patients did have cardiomyopathy. So very important to point of care ultrasound and keep that in mind. DVT prophylaxis, again, these patients are highly thrombogenic, so consider at least DVT prophylaxis. I have a couple of papers on that as well. Corticosteroids with WHO and CDC, there is no recommendation. They recommended not to use it, except if the patient has asthma or COPD exacerbation, along with COVID, and in patients who have refractory shock. However, SCCM did give recommendation to use in the cytokine storm in severe ARDS cases, which is the weak recommendation, but they have a recommendation. And I have certain slides, and I do think that's an important point here that we will discuss further, how and why and when we can use steroids in COVID-19. Was there a question or I don't know, I heard something in the background. So
No, go ahead.
Okay, so
I think we are going to take questions at the end of your talk.
I agree. All right, so now these are the general treatment recommendations. Then we go to hypoxemic respiratory failure. As mentioned, if they are not very hypoxemic, start with a nasal cannula, non-rebreather can be tried. Consider early intubation as opposed to BiPAP or CPAP, multiple society recommendations. Now, if you have to intubate, use rapid sequence intubation technique, which means paralyze those patients first. Of course, make sure with paralysis that you can ventilate those patients rather than just using sedation, because the huffing and puffing and cough can lead to a lot of droplets. So rapid sequence intubation is a recommended way from multiple societies. Use video laryngoscopy if possible. Of course, direct can be used, but video laryngoscopy, bronchoscopy can be considered, but video is the quicker one. Minimize circuit breaks, as I mentioned. And when the patients are intubated, use the lung protective ventilation strategies, just like we follow for with ARDS and protocol. Prone and paralyze as needed. Now, if lung protective strategy, prone paralysis, despite all that, patient is worsening, consideration of ECMO. Okay, so this is how basically we're going to treat these patients, and then we'll talk about some investigational therapy. There has been a lot of online stuff going on, whether this is true ARDS or not ARDS, multiple theories. Do not believe them unless you have a full literature review. I wanted to put that slide, top of the slide, the COVID-19 pneumonia. This mention, I think that was published in JAMA or something, that showed two variants of ARDS. They described an L to H variant, L variant, where the lung compliance usually in ARDS is very low, along with hypoxemia, it matches hypoxemia. They mentioned that initially these patients have a high compliance and they should not be treated with high PEEP and typical ARDS strategies. Once a patient gets converted into an H variety, which is low compliance, along with severe hypoxemia, then they require all that. And then the bottom line, there is a link. There is a very good commentary on why these patients have true ARDS. They can have the two variants, but they could represent the same spectrum of disease as we all know in ARDS. Bottom line, what I want to point out, that has been asked by multiple other subspecialty physicians to me, that is it ARDS or something else? It is ARDS. The definition of ARDS is within a week of insult, bilateral pulmonary infiltrate, severe hypoxemia, low PF ratio, and absence of cardiogenic shock. This is ARDS. And the pathophysiology of leaky capillaries is ARDS as well. So these patients are going to ARDS, but again, I will leave it here. It's a whole different topic and debate. These references are good to read to kind of understand what's going on. Okay. After this therapy, which is general therapy and ARDS therapy, what are the investigational approaches? FDA-approved drugs, we all know chloroquine and hydroxychloroquine, they are being used as off-label. There has been some initial data suggesting that hydroxychloroquine blocks viral entry into the endosome, and in vitro data suggests some utility. However, RCTs are lacking. There's a recent negative study that I'll go over in the next couple of slides. Other investigational agents that are available in use for use are remdesivir, which is an antiviral lymphocyte analog. Use it. We are using it along with, it's not a compassionate use anymore, it's for trial. Lopinavir and ritonavir now has a negative study, so we are not recommending it at this point until further data is available. Tocilizumab is an IL-6 inhibitor, and there was a positive study with role of tocilizumab in China, and that has many centers are using, including ours, and I think it's a very good response. So basically, at this point, remdesivir, tocilizumab, I'll talk about steroids, and chloroquine and hydroxychloroquine is still being used despite some questionable data so far. Now, just wanted to throw it out there. Just a few days ago, this is published in MEJM about the initial data of the compassionate use of remdesivir. They had a total of, I think, 50 out of 61 patients. They had a data on 52 patients who did receive remdesivir in the United States, Canada, and in Japan, 22 in, I think, Canada, 22 in the United States, and 9 in Japan. Very good response. Most of these patients got extubated, and the mortality of the patients who were on the ventilator was 13%, and those who were not on the ventilator was 5%. We all know that this is much less than what has been seen in China, what has been seen in Italy, and what has been seen in US. So I think that's a decent response study. I want to just put a quick comment on the chloroquine recent, this is the pre-published data from April 2020. So this is looking into hydroxychloroquine and its response in the patient, and they had 2 arms, 32 patients in a placebo arm and 32 patients in the hydroxychloroquine arm. And they did not find any significant association of hydroxychloroquine use and improvement in lymphocyte count or improvement in any other parameter. In fact, the patients who were given hydroxychloroquine had a higher rate of intubation or respiratory failure. That could be a coexisting, but there was no benefit of choosing hydroxychloroquine. So this is rather more recent negative study on hydroxychloroquine. What about tocilizumab that I mentioned? So this is the earlier data from China that showed the use of tocilizumab for suppressing cytokine storm with anti-IL-6. 20 patients that received it. 15 of those 20 patients did improve their oxygenation, which was 75%. 90% of those patients had improvement in their CT scan, and 85% of those patients had improvement in their lymphopenia. And I believe 80%, yeah, the C-reactive protein was also improved in 85%. And 90% of those patients, which were 19, were discharged on an average of 13.5 days. This is a very good study, and I'm going to throw it out there that out of 8 patients that we have used, including one patient at 82 years of age, all of them got extubated. Okay, so some of them are still in the hospital, but we have exactly the same matching result with tocilizumab in patients who were given, which I'll go over what are the indications to give tocilizumab. Okay. All right, so this question has been asked a lot as well about what do we do? Should we anticoagulate these patients therapeutically because they have high risk, possible high risk of thrombosis? So there is a study that's pretty recent as well. I think last month it was published, end of March, that showed out of 184 patients with proven COVID-19 pneumonia, there was a 31% chance of thromboembolic event, and out of those, 95% were PEs. Okay, so they were recommending in their study to have at least a prophylaxis, DVD prophylaxis, but if suspicion is high, then just use for those. However, we have guidelines from International Society of Heme that are recommending to use at least prophylactic dose of oh, okay, so I just heard that I need to speak louder. So yeah, I'll speak louder. So, and sorry about that if it was not heard before. So with International Society of Heme, the recommendation is to not use, also is to use prophylactic dose of Lovenox at least. And they are, there was a study of 449 patients, and out of those, 100 had received low molecular weight heparin, and they found out that those that received low molecular weight heparin, if they had a high sepsis score and high D-dimer, they did better than those who did not. So at least use the low molecular weight heparin on all of the patients, and if suspicion is high, therapeutic anticoagulation can be considered. Okay. What about prognosis? From China's experience, we know that 80% of patients with COVID will be having mild symptoms, 50% moderate and 5% severe, requiring mechanical ventilation. And that severe group will have a high mortality, right? 50 to 68% in China, around 60% in Italy, and in US, earlier studies were about 50%, but depending on the region, it's different. They deteriorate gradually with a median number of days from symptoms to ICU admission in severe cases of about 9 days. Okay. Pregnant women and children appear to have a better prognosis, and there was a recent study that I mentioned on April 3rd that showed about 1.3% involvement of kids in till the data where US were up to 170,000 cases, which is reassuring. Worse outcomes in patients of increased age. lung comorbidities, cardiovascular comorbidities, and obesity. Okay. Higher admission sequential organ SOFA score as well. Um, just respond. Okay, and then if they have high D-dimer, ferritin, and troponin levels, that is also associated with basically high or worse outcome. These are the SCCM recommendations regarding the management of acute hypoxemic respiratory failure, and I'll just summarize it for you. Basically, same, try to avoid non-invasive ventilation if it can be, early intubation, early proning of these patients, and then use of neuromuscular blocker recommendation, use of inhaled vasodilators like prostacyclines only in patients in which neuromuscular paralysis plus proning is not working. And if all three are not working, then ECMO is recommended. These are all kind of weak recommendations, but these are the recommendations from basically SCCM that we have discussed previously as well. Now I'm gonna quickly go over, especially for the hospitals which do not have a protocol at this point, I'm gonna just throw it out, our protocol, and there are some other online protocols with some other centers as well, but take it as you wish, but you know, at least this protocol will be on the presentation if somebody wants to take it to their hospital. If we have a patient with suspicion or confirmed who's not having any risk factors or oxygen, treat symptomatically. If they have risk factors but no oxygen requirements, consider hydroxychloroquine plus litro. And risk factors, we're talking about chronic lung condition, diabetes, hypertension, old age, and others. If they're requiring both oxygen and they have risk factors, then of course hydroxychloroquine plus litro we are giving, and we are following their markers to see if they are eligible for cytokine blockade, as well as eligibility for convalescent plasma. Okay, I'm gonna skip over this quickly. We are doing all these labs on admission, and then every second day or third day, we are repeating basically CRP, DIC, ferritin, and LDH, because that's what we are monitoring to see if they will benefit from tocilizumab. The next slide is our indications for IL-6 blockade. They need to be in severe ARDS with a PF ratio below 300 and worsening, of course. Less than 300 is mild, but it's just one of the inclusions. They should be in ARDS. Worsening with regard to their inflammatory markers. And what we are looking at, either 3 of the number A, which is IL-6 more than 400, CRP above 20, ferritin above 14, D-dimer above 1000, LDH more than 245. These, or if these markers are above 25% of upper limit of normal, and they do not have any significant contraindication that include more than 5 times AST/ALT elevation, pregnancy, low platelets, or hypersensitivity to drugs. So these are the general recommendations I would say that we look at, and we do it in collaboration of an intensivist and infectious disease expert. Our preferred agent is tocilizumab. You can do 1 dose, 8 milligram per kg, or may repeat 1 time. Okay. There are some, I think 4 or 5 trials on IL-6 currently. So I think that is something that has been tested. But remember, these are expensive medications. Even we were running out after using around 6 or 7 patients. Imaging findings, I will pass over. Remdesivir is in our protocol under trial. We are using it on some patients. And then convalescent plasma. We just started our first patient on Friday. One of my colleagues started it. I will see what's the outcome on that, but the indications for using convalescent plasma is pretty much similar, as I mentioned, for IL-6, a little bit loose. If they are going into respiratory failure or are already in a life-threatening illness with elevated inflammatory markers, then we are considering them for convalescent plasma based on availability. I'll give this reference. This is a study of 5 patients who received convalescent plasma. They were all intubated, and this is a study from Wuhan, and all of those patients did good. 3 of them were discharged, and I think at the time of the publication of the study, One patient was still there at 37 days, but he was doing well. So all 5 patients did well with convalescent plasma. So small study with decent results. There's a lot of data about steroids, and I just put these references. This is a study that goes over why and how steroids in viral and non-viral ARDS can help. And these are all the various study references that we don't have time to discuss, but I would recommend the audience who has interest to go through these studies that will go over the benefits of steroids in viral and non-viral. So one of the places that is using steroid is Sloan Kettering. It's a very good institution, and that's my parent institution. Currently, we are not using it, but they're using it. But I have plans to use it if we have tocilizumab out. But that's I just wanted wanted everybody to know that currently I'm not using it, but Sloan Kettering is using it. Okay, so the protocol for steroids is again high inflammatory markers, CRP above 10. Elevated ferritin levels up to 1,000, and if IL-6 is available, above 400. There should not be a bacterial infection or negative procalcitonin level, no current immunosuppression, and of course, severe ARDS. Now, they're using Solumedrol 1 milligram per kg for 1 to 2 weeks with the taper. The rationale behind steroids is the same as these patients are dying not of virus itself, but dying because of inflammatory storm or cytokine release storm. If you do not have tocilizumab and patients are dying because of inflammatory storm with very high CRP level, very high ferritin level, if you have IL-6, then consider those because steroids are cheap and they are available everywhere in England and Pakistan. We had a discussion today with our panel of friends in England, and that's what I recommended to them. And there will be a study coming out of Sloan Kettering, hopefully this week. I think that would be a good study to look into, which will have positive effect as per my initial discussions with them of steroids. But again, I don't have the study. This is based on their protocol and this is based on the discussions with them. But there are positive steroid responsive studies that have been published in 2017 in one of the previous slides that I mentioned with H1N1 pandemic as well as there are 8 or 9 RCTs that show steroid benefit in severe RDS. So consider it. So what I would suggest at the end is in Pakistan, if you want to use the protocol like I have or like some other online protocols you'll find in big institutions, use it. But at a time when cytokine storm is there and all the inflammatory markers are high and rising, consider some investigational approaches, just like I mentioned steroids, just like I mentioned tocilizumab and others. And hopefully that might help. Disclosure in our center, out of 8 patients I mentioned that received, all of them basically are extubated, are doing well. And so far, we do not have a mortality, which again, we do not have huge numbers, but I think partly is because we have tried all those medications in inflammatory storm, plus we are not overwhelmed our system at that point. So again, I think I'll end my discussion here and I will take questions.
Okay, thank you, Fawad, for a very detailed and comprehensive presentation. Now, I will go towards our panelists and ask them to introduce themselves and to begin with a very brief comment or question, just one or 2 minutes, and then we'll come back because we have at least, I think, 5 panelists today. So I would ask Samreen Sarfraz, if you would like to comment. Samreen, go ahead.
Assalamu alaikum. Can you hear me?
Gigi, sure, go ahead.
It was a very good lecture. I just want to say that in our center we are also using steroids because we are seeing whenever we see severe cases where there is an elevation of LDH and CRP and ferritin, we start off with methyl prednisolone. And then even in some of them where after 24 to 48 hours of steroids, we are not seeing any improvement, we have used tocilizumab. But the results are okay for some. I mean, it's a little premature to say what is happening. The thing that I would like to comment on is that some of our colleagues at another institute are combining tocilizumab with IVIG. I would like to know any experience of this, because they say that, I mean, they are a transplant institute and they say that they've dealt with cytokine storm in their patients otherwise as well. And they say that there is a good experience of IVIG when it is combined with tocilizumab, both given together in severe cases. And they're saying that they're seeing good results with it. So any experience of that?
So thank you. And I think it's a very good question. We do not ourselves have experience of combining IVIG with tocilizumab. I think they are very potent. I would worry that they might get better and get a superinfection later. Even with tocilizumab, we worry. I don't think so. There is any study being done with the combination of these two, but I would also ask other panelists, they may know something that I don't. Majid, do you have any idea, any experience with that?
Assalamu alaikum. I'm a pulmonary critical care physician. Excellent talk. No, I don't have any experience nor any expert knowledge of that. I would similarly be concerned, and especially in Pakistan, you know, in tocilizumab, for instance, any history of latent TB infection, for instance, is a relative contraindication, if not an absolute one. I would very much worry about getting an opportunistic infection, particularly TB. Through the combined use of the two.
Okay, let me go to Awais Masood. Awais, please introduce yourself and
Okay, thank you, Shahid. This is Awais Masood. I'm a nephrologist and intensivist. So again, very good talk, and I refresh my, update my knowledge on that. I think compared to 2 weeks ago and now, pretty much the same treatment we have been using, but I think we are using more anticoagulants now. Majority of the patient in ICU, we are using systemic anticoagulants. Patient who are not have any renal failure, we give them Lovenox, and if patient has a advanced renal failure, we use heparin. And what I have read that heparin and Lovenox have also anti-inflammatory action, heparin more than Lovenox, but again, Lovenox is easy to give. Again, I don't have any experience with the IgG antibodies giving for this patient. So that's all I can say.
So do you give therapeutic anticoagulation, or is it only prophylactic?
No, not therapeutic, not prophylactic. Prophylactic we have been giving from the start, but now we are giving therapeutic.
Yeah, I mentioned one of the study that did show, 31% rate of, thrombosis, and they were recommending therapeutic. But I think its opinion is split. But nobody will fault you for using therapeutic. I think Dr. Awais Masood, they're doing good in that aspect. I think that's reasonable to use therapeutic.
But I agree, it's still disputed. I mean, maybe next week we will not be doing it. This week we are doing it. So
no, I agree. I agree. If you're not gaining grounds, I think it's reasonable to do it because they may have a PE. It's such a high rate with these patients. I agree.
Actually, we also reviewed the report of biopsy. Actually, autopsy, unfortunately, from Louisiana. They published a study from the autopsies done on a patient who died from COVID-19 pneumonia, and most of the patients showed that. Nothing surprising. We already know that they have more like a thrombotic events, micro thrombi, most of the patient. So that's, and whatever else experience we have. So based on that, we are using a systemic or a therapeutic treatment for this patient, anticoagulants.
Okay, let me introduce, let me ask Mohammed Salim. I think he's joining from Pakistan and from, I think, Kotli. That's why I wanted him to have a chance to introduce and be our panelist. Mohammed Salim, please go ahead. Mohammed Salim, consultant physician from DHQ Kotli, Azad Jammu and Kashmir. All right, so we can probably try again. Asma Chima, go ahead, introduce yourself and comment.
Assalamu alaikum, everyone. My name is Asma Chima. I'm practicing internal medicine in Maryland. And Dr. Fawad Chaudry is very nice talk. Thank you for sharing with us. I want to ask about ECMO, extracorporeal membrane oxygenation, in life-saving therapy in patient with COVID in severe ARDS. Is someone using it, or do you think anyone is using it? What are your comments about it?
Yeah, so thank you so much for this good question. We have our team available for it. We have not used in our center. There is a weak recommendation from SCCM. If everything fails, consider that. I'm not sure if any of the other panelists have in their center used ECMO yet.
Yeah, so this is Avaz. So in our center, we are using it. Hopefully, of course, only a few patients so far. One actually of them, one got better and eventually extubated. So 3 or 4 of rest of them, they didn't make it. So we have been using it, yes. And actually yesterday we saw a patient who was sent to us for the same purpose from another hospital. We did not start him on ECMO, but we started him on nitric oxide. And so far he's doing okay, and looks like less likely he would need that.
Okay, let me go to Kaleem Ahmed. Kaleem, you are unmuted. Please speak.
Assalamu alaikum. Regarding this IVIG, the Survival Sepsis Campaign and Society of Critical Care has a weak recommendation of not using it against IVIG in COVID-19. They have data from published in the clinical infectious disease from Jiangsu province when they have used this modality in COVID-19 patient and there was no significant outcome.
Okay.
Gee, so now let me go to our
I just want to
Fizia
add,
is our panelist. Fizia, you want to add something?
Assalamualaikum. Assalamualaikum. I just wanted to ask what is the reason of the prolonged intubation? For instance, after our cohort of giving patients with tocilizumab, we do see a very good response in means of chest radiography getting cleared absolutely rapidly and CRPs going down. But we have been seeing that they still are on the vent and difficult for ventilation to be maintained, and hypercapnia is the major problem that we are facing. So, I mean, is it other nosocomial infections? We are a little braver for TB, but you know, why are we not being able to wean them off?
Fizia, this is in generic all the patients, or you're talking about some of those that have COPD along with that, or some other elements as well? Is this your experience with every single patient you have done, and how long you're talking about? 7 days, 2
Okay,
weeks, 3 weeks?
yeah, so the issue is that for all of the patients, well, they are on the vent, and for the rest of the patients whom we have not given TOSI, the X-rays are as bad as it is. So we do understand that it will take time for them to get better. But for TOSI, there's a remarkable improvement in the X-rays, and we have not been able to do CT scans to give a better, proper, you know, picture of it. However, the X-rays go absolutely clear within 24, 48 hours. However, our problems with ventilations are still there, and hypoxemia is there, but more so the PCO2s, the perfusion is so bad that we are not able with any settings to bring them down. I mean, like a PCO2 of 90s and 100s is something which we are facing. And for one of the patients, it's already been around 18 day of his admission. He's still not cleared of his COVID, and he's got his TOSI, and I think now probably he's developed a VAP, but for that also we've now stopped his antibiotic. He has very thick secretions. We've changed his tube a couple of times, and we keep on arguing about the question of getting an ETT, the tracheostomy done, but that's a problem again in Pakistan.
So yeah,
Right,
I think you're right. Go ahead.
yeah.
I'll just make a quick comment and I'll open it to the
Okay,
rest of
sure,
the panel.
sure.
I think you're right. Some of these do take time, and that sometimes is just the physiology of ARDS. Partly, sometimes you see high CO2 because many of us who do ARDS quite a bit, we know that sometimes it lead to what we call as permissive hypercapnia with the low tidal ventilation with stiff lungs. So we sacrifice CO2 for the oxygen. And then the third portion, I would say, there have been some studies done that show that these patients are hyper vasoconstrictor. The hypoxic response to vasoconstriction is quite a bit. So I think in those cases, consider using the inhaled vasodilators as well if you're not having a good success after tocilizumab. And the final comment is we have had one patient we received from another facility after 2 weeks or so, and he received toci, I believe, as well. So we are considering convalescent plasma. So I think sometimes, these ARDS patients just take more time because so much damage to their lungs, and then we cannot assess these days with the CT scan. I'll stop here and, I'll open it to a
I have one question, as a continuation. Because in tocilizumab, now some evidence is emerging that there can be a rebound after use of tocilizumab. There can be a rebound in the storm. It suppresses and then it re-emerges. So have you seen that, or what is your comment about it?
Yeah, very good question. We have seen in one, and that is why you can do, like he got better and started getting worse again, and we did use the second dose as well. It's been there, I agree, in the literature as well, not a huge literature, but it's there. But what else can you do? I think in that circumstance, after the second dose, it is still going downhill. I will consider our last option, that is convalescent plasma.
So there is a question why ferritin is raised in the panel or labs.
It's an inflammatory marker, just like CRP.
One of the reasons for ferritin to go up is actually because it's a macrophage activated system. And most of the people believe that this is actually HLH, not directly actually as an inflammatory marker itself, because your macrophage dies because of the IL-6, and also because inflammatory macrophage will die, and then you release your ferritin. And that's one of the reasons that they are seeing high ferritin in these patients. And that's why they're also comparing with this is a secondary HLH versus MAS syndrome, which is pretty much like your CART syndrome too. But this tocilizumab came in. Most of the data came from oncology.
Thank you, Farhan. Now, one question from the attendee is Mohammed Azim Imran. Please go ahead and give your question, introduction and question.
I am practicing family physician here in Faisalabad. I want to ask from Mr. Fawad. For me, actually, this is the cytokine response and the virus. There is a challenge. There is a going on war between these two things. That is the virus response and the body response of this in terms of cytokines. Is there any prediction or biomarkers available so we can judge pretend that these patient will develop the cytokine storm, so we can better intervene before the cytokine settings going on, damaging our lungs?
Yes, absolutely. And I kind of mentioned, and it's in my protocol as well. So basically, interleukin 6 itself may not be easy to do. So you follow basically CRP, D-dimer, ferritin level. If CRP is getting close to, if it is rising every day, getting close to 10, ferritin close to 1,000, D-dimer above 1,000, or all of just these are simple markers to do. If these are raising in those numbers, then you are heading towards cytokine release storm. LDH is another one, close to 200, 250. But again, it's more rising in the numbers they are getting up to. So you have to see really trending every other day or every day.
Wes Masood, in the same context, what we have learned over the last 2-3 weeks that the timing when you give the IL-6 inhibitors is also important. And if you anticipate the patient is, heading towards cytokine storm with all the inflammatory markers and clinical presentation or deterioration, I think it's better to give early rather than wait till late. So on the average, when patient is admitted, and we are giving within about 7 days, about that time. So if we are late, then it's too late.
Yeah.
All right.
I would say just do the basic lab the first day, and every other day or first 5 days, be very aggressive with these inflammatory markers. And as Dr. West said, I think within 7 days, we want to start those medications.
Fawad bhai, I have a question for you. I've been seeing a lot of people, especially my friends and colleagues in New York City, they're doing a lot of early proning. So the whole concept of early intubation was primarily run from control of infection versus, oh my God, this patient's going to die really quick on us. Now people are actually saying, because the mortality is so high, do not intubate this patient early. And they're saying early proning, awake proning, negative suction, and all that. So what's your take on it?
Okay, so that's an area which is, again, there are different online versus evidence-based discussions, not much evidence-based. So proning helps because most of the ARDS happens in the posterior part, because posteriorly our lungs are huge. So the reason for early intubation that was suggested earlier is to avoid various modalities like non-invasive ventilation, to avoid high flow above 30 liters, and just control the patient, do the proning after intubation. So that was the reason behind early intubation, to decrease the aerosolization, plus do aggressive critical care management early on, as opposed to sometimes we try CPAPs, BiPAPs in a non-COVID patients. Now, the question of should we not do it and prone it because mortality is high. The mortality is high because of multiple reasons. One of the reasons is not having those investigational therapies, like some of the centers who are not overwhelmed. And overwhelming, if you have 40 ventilators, you have 80 patients, it's not easy, and that's happening in New York. It's not easy to manage those patients by a non-intensivist. There are multiple reasons there. Now, early proning without ventilation is actually not bad. But it is very difficult. Keeping a patient, studies showed 16 hours of proning. It's not easy to do it without patient being intubated upside, lying on his belly. Forget about 16 hours, 10 hours is difficult, but it's a good concept. I don't think so there is any significant evidence at this point that it will help better than intubation, but I will put it to other panelists. One comment I would want to make though, if you are not intubating and patients can tolerate early proning, awake proning, some centers are doing it, I think do it. But if patients requires intubation, if you do the good critical care with all the things that I mentioned, and if you have those availability, I think intubation shouldn't have that much mortality if your system is not overwhelmed. I will leave it to others because we personally have not tried awake proning as yet. But I think in the panelists, some of the panel, speakers, some of the attendees might have done it.
Anyone in the panelists who would like to add?
This is Avas Masood. No, again, we have not done any proning on a patient who is not intubated as yet.
We have done proning on, we have done awake proning quite a lot, and we are seeing good results with it. And it really delays ventilation, and I think it's very helpful.
So Samreen, this is, so you guys have done a lot in a what PF ratio when they're going into severe, or you're kind of under 300?
No, when they're going into severe, when the PO2 FiO2 ratio is less than 300, when we are seeing that they are on 10 liters or 15 liters of oxygen, and the oxygen demand is increasing, or they're very tachypneic, the respiratory rate is above 30, then we try to do alert proning. There are some people who do not tolerate it and they don't do it, but there are others who do tolerate it, and wherever it is tolerated, we are seeing that there is an improvement in the oxygen saturation on the monitor, as well as there is a delay in the time taken for ventilation. And that's what I'm also seeing with early use of steroids, because when we see that they are hypoxemic and they have a high respiratory rate, and that is clinically they're in the severe category, and we start with methylpred early, then we see a little benefit in them. I mean, this might be just subjective, but that's the initial data that we are seeing.
And this is you're using steroids once they are based on the inflammatory markers, or you're just using it once they're becoming more hypoxic?
CRP comes pretty early, CRP and LDH. So and the NLR ratio. So we are seeing the neutrophil lymphocyte ratio if it's raised, and we're seeing quite a lot of that. I mean, 10, 15, 20. I mean, this is the NLR ratio that we're seeing. There's a lot of neutrophilia. The TLC can be above 20, 25, and with the neutrophilia present and lymphopenia. So a big NLR ratio, a high CRP count, and along with that, respiratory rate of more than 30, and hypoxemia. Evident on ABGs or desaturation on the oxygen saturation, then we just hit hard, because these people are usually presented on the 5th day or the 6th or 7th day, and we are thinking of now hitting hard and being a little aggressive with them. Along with HCQ, we start with methylpred and do proning and see the results. And the early thing is that I'm observing that there is a delay in the time for intubation.
Do you give them any light sedation or anything?
For proning? No, not yet. No.
So, and you're able to, I mean, they cooperate, the patients?
Yeah. See, there are some who do cooperate, and where there is a subset of patients who just refuse and say we can't do it. So then we don't force them. But whoever can, then we do insist that they should be made prone.
Yeah, we have a similar experience in our center as well, where we do encourage patients who are quickly ramping up in terms of their oxygen requirements to try it. One thing that occasionally helps is to actually make the bed slightly reverse Trendelenburg, about 10 degrees or so, so that they don't feel like the intraocular pressure doesn't increase too much, and it becomes a little bit easier for them to tolerate having their sort of head on to the pillow. Secondly, and importantly, we try to keep these patients NPO starting that point, because if they're quickly going up, as many people have already described, once you step on that ladder of increasing O2 requirements, some of these patients quickly progress to the point where they require intubation. So it can become a bit of a sign if you're thinking, proning, intubation. If you're even thinking about it, remember, you probably want to make that patient NPO.
Makes sense. Yeah, that's good. So I think it would be good to share that data once you guys have more patients. It's very good, very refreshing to hear that that's working well.
Okay, I have a question for Abbas Masood, because you're having these anticoagulation more. There's a question about this, that do you think that unfractionated heparin is better than a low molecular weight heparin, or vice versa, or what is your take?
I mean, unfractionated heparin has more anti-inflammatory action compared to Lovenox, and Lovenox have more than oral anticoagulants. So that's the status right now. But again, Lovenox is easy to be given unless patient has renal failure, and there is a reason that Lovenox cannot be given. We keep Lovenox. But patient with renal failure, with the GFR less than 30, they get heparin.
Okay, let me unmute Kaleem. He has some comments.
Yes, so I don't have personal experience, but a colleague from Long Island, in fact, my brother-in-law, he was reporting a lot of patients who are intubated are difficult to sedate and requiring multiple agents. So I want to see what other panelist has. Do they experience the same kind of thing, or is this some kind of anecdotals?
So I can I can share. I think not much from my end. Mostly when they're proning, we paralyze anyways. So I have no problem. As I said previously, propofol versus propofol with paralysis versus fentanyl with paralysis we have used. It has worked well. It's just sometimes ARDS patients become difficult, but then when the paralysis hits, as they're prone and all that, it works out well. But nothing out of norm on my end.
Yeah, same way. I mean, most of the patients are paralyzed anyway, and the same then we use propofol and fentanyl also at the same time for pain. So this combination works pretty okay.
So, hearing from some of the colleagues from Pakistan about their experience, are they paralyzing the patient as well, or?
Yes. So we are using cisatracurium, and because sedation is a major problem with us, we don't have fentanyl, so we are using propofol, dexmedetomidine, which is Presidex, or midazolam and ketamine. These are the options that we have. So we make a combo with either propofol or ketofol, and still if we have a problem, then cisatracurium. So these are the options that we have available. Fentanyl we don't have.
All right. So one raised hand is from XT1254. I would request. Okay, go ahead first. You're unmuted. XT1254. You have to unmute yourself as well.
I do not have any question.
Hello?
Hello, I do not have.
Okay, all right, thank you. I'll lower your hand. Okay, so I think we are going over, so I would say at this point to have a one last round of our panelists.
Shahid, I'm wondering if anybody has any renal related issue. I mean, I'm here to, because I'm in the front.
Right.
Yes. Well, I had some points written for my presentation, which I would like you to make. Well, we are seeing a lot of hyperkalemias and metabolic acidosis on top of whatever respiratory acidosis we have. Yes, and we've already had 2 patients who've had required CRRT, but what we're seeing is a persistent hyperkalemia in most of them. So a couple of them, not more.
You do CRRT there?
Yep.
Okay, great. So what we do CRRT, actually, we are doing like a short, we call it a shift therapy or PIRRT, 6 to 8 hours. You don't have to do 24 hours. And we use very high, dialysate flow rate, like a 50 to 60 ml per kg per hour. And that has been working pretty good for us.
Right.
So we've converted from infectious disease specialists to intensivists and nephrologists and cardiologists because of resource limited things. So we are supposed to do everything now.
I would like to add on to that. I would like to ask about fluids, because there's a lot of contention about how much fluid should be given. Some people say that you have to restrict fluids, and then there's this risk of this thing about the heart and the kidney all getting involved at the same time. So how much fluids should be given, basically, or is it just case to case?
That's a great question. Actually, that we learned over the last 2-3 weeks. Initially, when we start seeing this patient and we were following like restrictive or fluids given to patient, but then about second week, we realized that we are drying them a bit too much, and that actually worsening their renal function. So we try to keep a euvolemic. Don't have to be hypervolemic, but please don't dry the patient too much. So that's the lesson we learned over the last 2 weeks.
All right, great. So yeah, I think that's a good, Abbas, you reminded me that I think going forward, we'll introduce our panelists as well as the speaker in the beginning, so that people can tailor their questions according to the expertise of our panelist of the day. But for now, I would say let's have a quick round around our panelists for our speaker or our anyone. Just comments and so that then we can close today's session. Awais Masood, you are first.
I mean, I think we discussed pretty much a lot of topics. So I think I would just wrap up from my perspective, from renal perspective, that again, don't try to drive patient too much, but at the same time, make sure patients are not volume overloaded. And if we're using CRRT or dialysis, you start using early. And you're anticipating that patient is going to renal failure. These patients need to be started renal replacement therapy early rather than late.
All right, thank you, Awais. Farhan, you're next. You're unmuted. Farhan Kadir. Unmuted.
Haji. So I'm also a nephrologist, and my only take is that I believe personally, based on my experience taking care of these patients, if you see an ARDS looking patient treated with like an ARDS, and we have so much data how to treat them, but if you have a patient who actually has a very good compliance, please do not treat it like an ARDS. Do not write them out. These are the patients who are going to have an AKI. Early CRRT versus late CRRT. Remember, early CRRT will release IL-6, which is documented evidence. CRRT does release IL-6, so when you treat patients with this, it can release IL-6 and cause more thrombosis and cause thrombocytopenia too. So CRRT comes with complication. If you need to treat it for ARDS, yes, please. If you're treating it as a thrombotic complication with the L type, please do not switch your gear and try to treat them like an ARDS. That's the only thing I have. Thank you.
Thank you for Farhan. Next is Fibzia. Harikar, please go ahead.
Yeah, I think it was an excellent presentation, and each time we get to learn things which we can further implement in our system. And I feel that in some of the centers in Pakistan, we are doing whatever can be done and in these circumstances. So.
Thank you, Fibzia. Majid, you're next, unmuted.
Thank you, Dr. Fawad, for the excellent talk, and to everybody else for the wonderful questions. I would echo what everybody else said. I think the best thing to do is to practice evidence-based medicine even during a pandemic. So the reality is that even in peacetime, even in the best of times, we don't do a particularly fabulous job sticking to evidence-based medicine. And that is why the whole field of quality improvement exists. The reason is we know what needs to be done, and yet we fail to do it. Even in the best of centers, the richest of centers across the world. And whenever folks have shown that they simply stick to what's borne out by evidence, outcomes improve, even locally, even within the confines of one hospital. So remember, what are the basics? There's lots of things to think about when it comes to ventilator management, ICU management. I posted some links in the chat forum here. Folks can also save the entire chat. There is an icon to the right of the chat box. You can click it and save the whole chat for the day at the end of every one of these talks. But there's the FACT trial that talks about making sure your patients remain dry. That can free up the ventilator up to 2 days ahead of time. There's the ABC trial that talks about daily sedation awakening trials and spontaneous breathing trials, which helps get patients liberated faster. These can help with mortality. There's good data on proning as well. Remember the basics, and of course, embrace new data and new evidence when it comes to the four, but don't jump to doing fancy things that haven't yet been borne out by evidence. Because this is a mistake that humanity has always been making, and we always suffer, and our patients suffer because of that. You can already see that unfolding within this pandemic. One a short documentary, commentary by an Italian physician who is a bit of a celebrity in Europe, right? And he said, what, I think this isn't really typical ARDS. And unbeknownst to him, everybody threw out all that they knew about ARDS, and now they're all trying to do, looking for the fancy magic pill. And of course, who else, but at the forefront than us Pakistanis, we're always waiting for the miracle, the savior, right? The magic pill, I'm definitely a victim of that too. I'm definitely to blame for that. But I think we need to really stick to the basics and embrace new data when it shows us something of value.
Okay, great. Very good lessons that we all should remember. Majid, thank you. And now let me once again try Mohammed Salim, if I can get him from Pakistan. Yes, Mohammed Salim.
Hello.
Ji,
Can you hear me?
go ahead.
Can you hear me?
Ji, bilkul.
Yeah. Assalamu alaikum. It was a very nice presentation and very nice discussion. I had a question that there is increased mortality in hypertensive patients. So is that due to the involvement of ACE or some other mechanism?
I think Avais, you can take it, or after that, then Fawad.
Yeah, I'll take it. I mean, there is Dr. Salim. This has been a suggested mechanism that they might have more expression of the ACE2, actually ACE receptor or ACE2 receptor. But again, that's again controversial because in some studies show that ACE2 receptor could be protective also. So again, nobody knows what exactly is the reason behind that.
All right. So Fawad or Farhan, you want to add?
Yeah, I'd agree with Avesbhai. I think it's not literature proven at this point. There is controversy about it. It's true that chronic lung conditions, including hypertension, diabetes, we have seen a bad outcomes in obesity. So yeah, nobody knows truly.
Okay. Anyone else want to add? Farhan?
I don't think so I have anything to add on. Just a bit that coexisting condition does increase the risk, which we already know. So I don't really know if there's any correlation between the two, unfortunately.
Okay, great. So Samreen, Sarfraz, you're the last in our round of rounding up and concluding this session. Please go ahead.
This was a great talk. It covered most of the things about severe patients. I would just like to say that in Pakistan, we are navigating between seeing a cytokine storm and the high endemicity of TB that we have. Tocilizumab is a double-edged sword, and we are forced to use it. I mean, based on just because we don't have like the facilities to do IGRAs urgently, or even Montoon's test, and Montoon's test is not even reliable in Pakistan. So I am dealing with TB quite a lot. I'm a TB specialist. So the thing is balancing the fact that there can be a TB reactivation and not to use tocilizumab because of fear of TB is really difficult for us. And we are just going ahead and taking a risk because right now it's their life which is at risk, and we can always take care of TB later on. Sometimes we end up doing that.
Right, right. So at the end, I would ask both Samreen and Fivzia that if you and any of the other attendees from Pakistan know of other ID specialists from Pakistan ID Society, leadership,
Yes.
or
Yes.
so please forward their name and contact to us so that we can include them, learn from them, ask them what is going on in their part of the world and city and institution. I think that would be great for all of us.
Sure.
Dr. Sobia from KE University. I know Dr. Sobia, ID specialist there.
Okay, great. So please forward your, to the appnamerit.com and appnamerit@gmail.com, as well as our WhatsApp group. And Walid can also reach out to you to get those names, our coordinator.
Sure.
Thank you all.
Thank you so much.
Thank you, Fawad, for a great presentation, and panelists, always great group. and attendees. I always love attendees. Without their participation and their keen interest in this activity, it cannot be that successful. So until tomorrow, thank you. Assalamu alaikum.
Thank you, APPNA Merit. Thank you, Fawad. Allah Hafiz.
Thank you, everybody. Take care.